Good morning, good afternoon, good evening, wherever you are. I'm Martin McKee, and welcome to this session entitled Achieving Progress on Anti-Corruption and Accountability. So today we are going to discuss something that isn't usually spoken about in polite company: corruption. For many years, Transparency International has reported how in many countries, the health sector is the most corrupt. There are many good reasons for this. Many of the transactions, whether purchasing medicines or technology, or the interaction between the health worker and the patient, take place out of sight. But we cannot afford to ignore this any longer. Our governments have committed to the Sustainable Development Goals, and with them, universal health coverage. But we know that many of them will never achieve it until they start tackling corruption. Quite literally, corruption costs lives. The ACE Consortium, Anti-Corruption Evidence Consortium, is a partnership with universities in London, School of Oriental and African Studies, London School of Hygiene and Tropical Medicine, and in Bangladesh and in Nigeria and Tanzania, and you'll be hearing from all of them over the next 2 hours. This session starts from the premise that we all accept and we know that this is a problem. We're not going to say yet again, something must be done. This is about the search for solutions. What can we do about this? Now, before I introduce our speakers, I want to remind you that, or mention to you that there is a Q&A panel. And there we would encourage you to post questions which we will answer at various stages during the next 2 hours. And in addition, there will be some polling that will be coming up because we will be inviting your comments on some of the issues, some of the drivers behind corruption and what can be done about it. So I'm going to stop now and I'm going to introduce our first speaker. Great pleasure to introduce Professor Mushtaq Khan, who is the Executive Director of the Soas ACE program, who will be introducing the health research component of what is a much larger project on corruption. Mushtaq, over to you.
Thank you, Martin. It's a great pleasure to introduce very briefly the work that we at Soas ACE are doing. This is the consortium that Martin mentioned, led by Soas, University of London, which includes LSHTM and many other partners, many of whom will be speaking today. And it's a new approach, an evidence-based approach to anti-corruption. We know that a lot of effort has been spent on anti-corruption in developing countries. We have spent a lot of time and resources on transparency reforms, accountability reforms, procurement reforms, in improving the rule of law, in improving accountability and transparency systems. But we also know that the evidence shows that much of this has not produced very good results. And the small results that are occasionally produced are overturned, particularly in the vulnerable and poorer countries that we are most concerned with. And we at Soas ACE argue that this is not an accident. It's not happened because of a lack of political will, or it hasn't been tried well enough. It hasn't happened across countries, and there are structural reasons for that. These reforms assume that countries are almost rule following, that most people, most of the time, are following rules, and a few people are breaking the rules. If that was the case, which is a reasonable assumption in advanced countries, then a lot of the observation of violations, when people don't pay taxes, or people are doing procurement fraud, or people are behaving in as free riders, are actually picked up by peers. And when prosecution or corrective action starts, the peers provide the evidence, they support the enforcement, and corrective action is then, in many cases, successful, not always, but it's often successful. The problem is that this is not a situation that is typical of most developing and emerging countries, and not because of cultural reasons, which is the usual explanation given. There are systematic structural reasons why developing and emerging countries are different. First of all, you have to remember that developing countries have maybe 70 to 80% of their economies in the informal sector. That means that most activity is of such low productivity and people are so poor that most people are not within the regulatory framework at all. That's a staggering fact to keep in mind, that 70 to 80% of your economy is actually informal. The people at the top, on the other hand, the powerful businesses and the big politicians, are few in number. The number of sectors that are very competitive are few in number. They usually know each other, and they find informal ways of doing business and informal ways of enforcing contracts. So the powerful actually don't need well-working courts and a rule of law in many cases. Occasionally they do, but in many cases they don't. And therefore, actually, the powerful are quite happy to collude with each other and carry on their businesses outside the framework of a rule of law. That means that the real demand for a rules-based system where the rule of law is enforced for everyone is absent. Now, if you begin with that perspective and ask, well, these are the adverse contexts we are working in, what does it mean to say that we are going to improve rule enforcement and anti-corruption? We have to start thinking out of the box and very differently. And we argue that there are lots of things we can be doing, but we shouldn't just be relying on the standard approaches. The approach that we follow in the Soas ACE program is one that is neither seeking to immediately change the systems of these countries to become fully rule following, nor is it focusing on individuals and saying if we can identify the bad eggs and prosecute them, we make progress. It operates at a meso level. It operates at the level of activities and sectors, and it's based on an evidence-based approach trying to figure out how to improve outcomes in specific sectors. And this is actually the most important aspect of our research design. So for example, today we'll be talking a lot about absenteeism by doctors in rural health clinics. This is a form of corruption because doctors are public servants. They have contracts which require them to do some service in rural health clinics. They violate these contracts in their own self-interest, and they do so with impunity. And if you try to address this with the standard approaches, the government of Bangladesh, for example, requires doctors in rural health clinics to sign on with fingerprints and biometric identification. And it's on public websites. You can see at any time, 30 to 40% of doctors in rural health clinics are absent, but nothing can be done. And nothing can be done because the scale of violation is so big, so many people are violating, and they're powerfully connected, that any kind of enforcement on the traditional enforcement-based approaches don't work. So, and this is not just in the health sector, this is across sectors. The nature of the problem is that the scale of violation is very large and lots of people are violating. What do? Our approach is to begin by understanding sectors really well on an evidential basis. We spend a year or two just understanding a particular activity like absenteeism and understanding why different kinds of doctors might be violating. And one of the core insights of our approach is that in a developing country, people in the same sector might be violating rules for very different reasons. Some might be violating because they can't do their everyday activity without violating, because everybody else is violating or the rules are set up wrong. And some might be violating because everybody else is violating, so they follow the rest. And some might be violating because they're the real bad eggs who will not adhere to the rules, whatever you do. And I think it's really important to distinguish between these different kinds of violations. Because if you try to randomly pick up people and try to address the issue through enforcement, you actually go nowhere because you find that nobody speaks out, nobody gives evidence, and the courts also don't function very well because there's politicization all through the system right up to the very top in developing countries. The only people, by the way, who are successfully prosecuted for corruption in developing and emerging countries often are members of the opposition parties, and successful prosecution in those cases has other reasons, not the ostensible ones. So once you identify these different reasons why people are violating, you find that many people actually don't want to violate. And if you can solve in a feasible way the issues that help those people start to comply, you can then isolate the bad eggs, and it becomes easier to shame them and to force them to behave. And even if you can't get every one of them to behave, you've actually improved the development outcome hugely. So that is the sum total of the Soas ACE approach. It's incremental, it's feasible, it recognizes configurations of power and interests, and it tries to understand different types of violations and tries to get as many people within a sector to comply as possible to achieve a good development outcome. So I'll stop there because we have a very tight schedule, and we'll come back in questions to elaborate these things, and I might even give you examples from other sectors that we are working in to elaborate what we are doing. Thank you, Martin. You're on mute, Martin.
I know, sorry. Thank you very much indeed, Mushtaq, for that. And now we're going to go into a series of 3 sets of presentations from the 3 partner countries where the field research is being done. We're going to begin with Bangladesh, and I'd like to introduce Dr. Nahitun Nahar from BRAC, along with Mir Rahinul Islam, also from BRAC, and they're going to be talking about absenteeism among public sector doctors in Bangladesh. So please, Nahitun.
Thank you, Martin. On behalf of Bangladesh team, I'll briefly share some of the highlights of the qualitative study that we have conducted on doctors' absenteeism in Bangladesh. You may be aware that in Bangladesh we have a pluralistic health system, and we actually have a quite extended healthcare infrastructure under our Ministry of Health and Family Welfare, which is divided in 6 tiers from central level to even community level. And in Bangladesh, we achieved some improvement in terms of some key indicators in over last 1 decade. But with this improvement and even after having the extended infrastructure, in Bangladesh, we still struggle with providing healthcare services, especially to the poor. Next. So one of the major challenges that our health system actually faces is with human resource for health. And in Bangladesh, there is not only shortage, but also geographical maldistribution of healthcare providers. For example, we have 1 doctor per 10,000 population in rural area compared to 18 in the urban area. So given this background, actually, we initiated our a study in Bangladesh where we wanted to explore the conditions that causes irregularities leading to inappropriate healthcare by the provider. Next. So in our study, we mainly focused on doctors' absenteeism because this has been a long-standing problem for us. A survey was conducted by our Anti-Corruption Commission in 2019, which shows that from 40 to 62% of our doctors were absent in their rural workplaces. And our Honorable Prime Minister has repeatedly stressed that if this tendency continues, then people will be deprived of basic healthcare services. Next. So government has tried actually several policy options to address these issues. For example, we have the rural compulsory service provision policy. Government also tried an initiative like Hello Doctor while making sudden visit to check doctor's attendance, and we have our biometric attendance monitoring system installed by government from sub-district level. So in this study, actually, we followed the strategy which not only focus on socio-economic but also on political context in order to construct some novel interventions. Next. So our broader study, actually, we applied a phase-wise approach where we started with a literature review. Then we did a stakeholder workshop, and then we conducted our qualitative study. At the end, we did our quantitative study where we did a provider survey, and we did DCE, district choice experience with the doctors in Bangladesh for the first time. Next. So in the qualitative study, we conducted 30 in-depth interviews with doctors who were working in the rural facilities from 3 divisions. And we wanted to explore not only the root causes, but we also wanted our qualitative study to support designing our provider survey and the DCE. Next. So this slide actually summarizes some of the drivers of absenteeism that appeared from our study. As you can see, we identified particular reasons within health system and also political context and infrastructure that makes the rural placement difficult and sometimes dangerous for our doctors. To share some of the insights in the next slide. For example, almost all doctors, they mentioned that their living and working conditions were very poor. The facility did not provide any transport for them, security was one major reason they were demotivated to stay. They were frequently threatened and abused physically and verbally. And they had to take additional tasks apart from their regular activities, and they struggled to maintain work-life balance. And also they couldn't provide full range of services to their community because of shortage of supplies, which also demotivated them to stay in those rural facilities. And they hardly had any opportunity for higher education, which was one major reason for the junior doctors. They were demotivated as they couldn't have any career progression in that areas. And prolonged service that they were giving, it was not considered for as a criteria for their promotion. And private practice was actually another reason, because the rural people were not able to afford their fees, so they were practicing somewhere else. And the absenteeism tendency were actually higher among the female doctors because of their health, family, personal, and mostly because of their safety issues. The respondent, everyone, they stressed that stress on poor relation with the community, and almost everyone, they mentioned that they suffered pressure from the local community for various reasons. And the doctors, they found the biometric actually of little use, because the biometric was not counting the additional hour they were serving. And almost everyone, they mentioned that the disciplinary action against absenteeism was weak and complicated and lengthy. Next. So apart from these structural and context issues, our study found that there were issues of informal payment, networks, etc. Almost all respondents, they have reported that the transfer process was not transparent, and they reported about bribery and unofficial payment. There were a group of doctors actually who paid unofficially to escape their rural placement. And the amount of unofficial payment, it varied based on transfer site. For example, to have a good transfer in urban or peri-urban area, I mean, they needed to pay a higher payment, obviously. Dual practice was also reported. Some of the doctors, they managed it through half salary, where they had mutual understanding with the staff in the facility not to report their absenteeism. Absenteeism also depend on the social, political, and professional network of the doctor. I mean, there were a second group of doctors who were able to escape their rural placement by using these various networks. And then there were a third group of doctors actually who were present in the facility, who were serving the community, but they were dissatisfied because they were vulnerable to their environment. Then there were a fourth group of doctors. They were quite a minor group actually, who were present there, who were serving their community, and they were satisfied actually with their rural placement. The reason was they were from their own locality, they were serving their own people, and also they managed to build a good rapport with their local community from the very beginning as a coping mechanism. Next. So the study shows that almost all doctors actually were unhappy with the rural placement. Some managed to escape and some stayed back. But the question is that which of the drivers of absenteeism that we found can be addressed, and which group of doctors will be interested to buy in any anti-corruption strategies? Should we focus on strategies like surveillance and monitoring mainly? Should we focus only on doctors who are guilty of absenteeism? Because from our study, it is apparent that those who have relatively power, who are powerful, they will not be interested actually in buying in, or they will not be benefited with any such strategies. So the anti-corruption strategy should also focus on the doctors who are actually present there, who are serving, and who are vulnerable and who are taking up the stock of their absent colleagues. And for them, a local level solution is needed to build. We need to build a supportive environment for them, and specific incentives need to be designed for them, because for absenteeism, there is no one solution for everyone. And it is very important actually to identify the difference between the actors, I mean, who benefits from such an informal system and who loses, and that can lead to design a specific incentives for the doctors. And to explore these areas further and to explore the answers of these questions, we then conducted our provider survey, and my colleague Raihan will be now sharing some of those findings. Thank you.
Thanks very much. So moving rapidly on. Raihan.
Hello everyone, I am Raihan Islam and I am going to talk about the influential factors of rural absenteeism among public sector doctors in Bangladesh. So based on our qualitative findings, we have designed our provider survey. It's basically a facility-based cross-sectional survey which was done in 4 government hospitals in Dhaka city. In this survey, 308 doctors with rural experience were interviewed. So for conducting the survey, we have arranged a briefing session where we have discussed the purpose and objectives of the research at each facility. We have collected their basic information, work experience, and information about their professional affiliation and networking in the survey. For the analysis, we have used simple and multiple logistic regression to determine the influential factors of absenteeism, and in the regression analysis, we have assigned uninterrupted rural service as our outcome variable. A threshold value of p-value less than 0.25 was used to select the indicators for final analysis. So let's have a look at our respondents. Almost half of our respondents were male and most of them were from 28 to 35 years of age. Approximately 1/3 of them were with an MBBS degree and half of them were enrolled in post-graduation degrees. So now in Bangladesh, every government doctor has to serve at least 2 years of mandatory rural posting at the beginning of their public service. So when we have asked the respondents that did you serve your mandatory 2 years of rural posting uninterruptedly, 74% said yes and 26% said no. And the reason for doing so were official training opportunities, family reason, and others. We can also see that there is the difference in the reasons based on their sexual orientation. We have also asked them that did they face any challenges during their rural posting, and 96% of the respondents responded affirmatively. They said that physically unsafe environment, unable to seek help from the rural influential people, social link, and verbally abusive behavior were the major challenges. Here, who are the influential people mean? The influential people are the politicians, ex-politicians, powerful businessmen, or anyone who has control over the community. They also mentioned that isolation from the family, absenteeism of staff, and physically abusive behavior from the community was also challenges they faced during their rural posting. So with this information, we have forward to regression analysis, and for the regression analysis, we have considered 20 indicators under these 4 categories, which are socio-demographic characteristics, their preferred career path, their rural work experience, and networking. In the final analysis, only 9 indicators were considered, and you can see the results of the regression analysis in the forest plot. We have found that respondents who had connection with influential people in the local community were 2.6 times more likely to serve in the rural facilities continuously compared to those with no connection. And also respondents who served their entire rural posting continuously reported higher workload compared to the respondents who didn't. So finally, to summarize our findings, we conclude by mentioning that absenteeism of the doctors burdens staff who remain at the rural facilities. Hostile environments have a negative impact on rural retention that we often neglect. Also, respondents' connection with the local influential people plays a crucial role in their absenteeism. So we would like to suggest that anti-corruption policies should be taken considering these points for designing effective rural retention program. Based on our work, we have published some publication, and this is based on our qualitative findings. This is based on our review findings. So we are now working on our quantitative working paper. We have also presented 3 poster presentation in this conference, which you can find in the poster gallery. We also acknowledge the continuous support and cooperation of our collaborators in this project. And if you have any question, you can post it in the live Q&A section. Thank you for your patience.
Thank you so much for that. And as you said, please, to those who are attending, do post questions in the Q&A, and we will come back to them afterwards. So in our next set of presentations, we're going to change continents. We're going to move to Nigeria, and we're going to hear two presentations from our colleagues at the Health Policy Research Group at the University of Nigeria, who will continue with the theme of absenteeism. So if I could invite Prince Agwu to come on to open up your camera and become live and tell us about redressing corruption, insights on how absenteeism manifests at a community level and its socio-political drivers. And then you will move on to introduce your colleague, Aloysius Odi. Thank you.
All right, so thank you, Martin, for a wonderful moderation. So we are going to be looking at absenteeism of primary healthcare workers, socio-political drivers, and anti-corruption findings from the field in Nigeria. Okay, sorry, I find it very difficult to move my slides. All right, so the study on the health sector corruption, we've done a systematic review. We've equally done a nominal group technique, and we identified different corrupt practices, such as absenteeism, informal payments, and a good number of them. But we did a ranking through the systematic review and the nominal group technique. Absenteeism topped the list. So we went to the field, conducted a study across 10 primary healthcare facilities, aggregated from about 6 selected local government areas in Enugu State, Nigeria, which is located in the southeastern part of Nigeria. 42 in-depth interviews were conducted with supervisors, HODs, frontline health workers, health facility committee chairpersons, and about 9 focus group discussions and more were conducted with service users. Yeah, so findings on political influence on absenteeism, we've discovered that some persons get jobs through political connections and kinship affiliations, and these persons who end up giving them these jobs politically and on the basis of ethnic sentiments usually tends to protect the health workers. We've equally had situations where some doctors who are employed who get more pay tend not to come to work and are not sanctioned for it. And that's simply because they have a way of exchanging gifts, giving gifts to their colleagues, giving gifts to some persons in authority who end up covering for them. The personnel unit is the unit in the local government that is responsible for employing the health workers and equally responsible for determining their payment. And we've discovered that some of these health workers who are perpetually absent have some form of relationship with persons within the personnel unit that tends to cover for them. And at times what happens is a situation where these health workers tend to exchange a part of their salaries for the covering they get from persons within the personnel unit. We've equally found situations where the health facility committee chairpersons, comprising of persons from the grassroots who should somehow take up responsibilities of the health facilities, try as much as they can to make sure these health facilities are up and running. They sometimes get themselves into some compromised states where they tend to accept political positions from local government politicians, even from state politicians, and some of them strive to be in the good books of the HOD of the health unit because they would want to get opportunities where they can make some money, such as seminars and such as workshops. And equally, the personnel unit, in line with the local government authority, usually carry out some verification process, which should ordinarily be a way to curb absenteeism amongst the healthcare staff. But however, we've discovered the verification process tends not to be effective. And it is usually because the health personnel, the personnel unit, together with some members of the authority at the local government level, have a way of compromising the process. There are equally cases where sanctions have not been effective, and we've seen a case where OICs complain about being in authority yet not having the power to sanction erring staff. OICs are usually persons in charge of facilities. We've equally discovered where the OICs, for want of keeping their jobs, are afraid of sanctioning staff who tend to be politically protected, so that they could keep their jobs. The Local Government Service Commission carries out some form of oversight on local government authority. And there are cases where corrupt cases should be reported in Local Government Service Commission, where the local government authority tend not to act. And we've discovered, because of the fact that the Local Government Service Commission is usually headed or is headed by a politician, there is some form of political influence happening at that level. And that's why even when cases of corruption from the local government are taken to the Local Government Service Commission, we end up seeing nothing being done about them. We've equally discovered cases where staff who are politically protected, instead of getting dismissal or perhaps having their salaries cut short or not paid at all, or perhaps suspended, they are transferred to some other facilities that are where they will be less bothered. And there are situations where these staff tend to influence their transfers themselves. They tend to choose where they would want to go and when they would go to wherever they would want to go. We've equally discovered cases where the local government chairperson usually tend to act swiftly to corrupt cases reported to him when those corrupt cases are happening within his own community. But from the field, respondents were saying that if a particular local government chairman isn't from their own local government, isn't from their own community, beg your pardon, they find it very difficult to have access to him or her. Health facility committee chairpersons and community leaders sometimes tend to not confront the local government chairperson, and that's simply because they wouldn't want to lose out when it comes to allocations and appropriations. Yeah, so we've had few cases where anti-corruption was somewhat successful. You know, a first case is that of a HOD who wanted to stop a perpetually absent staff from not being absent. The case was the absent staff, because of the fact that she's politically protected, got admitted into school, and rather than leaving the facility and going to school, she decided to be running the facility from her school. And when the HOD decided to act on that, she was threatened by that very staff. At the end of the day, we discovered that the HOD had to stand her ground, talked to the local government chairperson and insisted that the health staff should hand over the facility, since she should be on study leave, supposedly. And by virtue of the case of threat of life, she involved the police. And it was reported that at the end of the day, the absent staff had to hand over the facility to someone else and focused on schooling. Yet nothing was actually being done to her because of the fact that she's politically protected. There's equally a case where health workers mobilized patients against a corrupt OIC. As at the time we were in the field, the petition had reached the State Ministry of Health, no longer at the local government level. And from what we were told, something was being done about that. There's equally a case where a staff was perpetually absent and decided not to leave that facility. That facility happens to be a busy facility and at the heart of the urban, at the heart of Enugu urban. Because of the fact that she is politically protected, the OIC couldn't do anything about it. Co-health workers couldn't do anything about it. So what happened was the World Health Organization usually carries out routine visits to these facilities. And the case was reported to the World Health Organization staff. And we saw that the World Health Organization staff went to the HOD of Health and insisted that that staff must be removed. After a while, we discovered that yes, indeed, the staff was removed from that facility to a less busy facility. Perhaps because she's politically protected, that might be why there was no sanction method on her, other than just a mere transfer from a busy facility to a less busy facility. And lastly, we've had situations where persons in the diaspora that usually fund health facilities would insist that the right things should be done. There's a case where a staff who was absent in a particular facility regularly, when the community persons went to the local government to transfer her, the local government authority refused. Not until persons in diaspora who are responsible, usually they tend to fund the facilities because of shortage in funds coming from the local government. So they insisted that that staff should be taken away, and there was some level of success. So this is just a case of absenteeism happening as a result of political influence. And we've seen that there are actually viable grassroots mobilized based anti-corruption approaches that can be taken. So we acknowledge our funder, Soas is Anti-Corruption Evidence Group. Thank you so much. Thank you. So over to you, Martin, please.
Lovely, and thanks. And I think Aloysius is going to continue on that theme in the next presentation from Nigeria. Yes. We have a second presentation, Prince.
Hello, Martin. Thank you for the opportunity. And Prince Agu has done a very wonderful job. He has made my job easy. So I'll just say a few things in part of the literature. Can you hear me, please?
We can. Thank you. Great.
All right. Okay. My name is Aloysius Odi, again for Health Policy Research Group. So our previous research has shown that where there is political protection.
Sorry, can you just make your slides full screen there?
All right. I'm trying to do that now.
Yeah.
Okay.
And you only have a very short time, I'm afraid.
Wow. Can you, has it been sorted out?
I think just go ahead, because in fact you have just about 5 minutes for this, and I see you've got 10 slides.
All right. I don't know what is going on. Okay, so I'll just give more information regarding what Prince Agu said. I'll just make it very short and simple. What we should look at when we talk about political protection is that there is a form of political trade-off and navigation of complex relationship at the local government level. So somehow political protection creates a system where everyone gains. Everyone gains in such a way that the politically protected staff get to live their life the way they want, engage in other businesses, and may not attend to work whenever they feel like. And at the end of the day, we found out that health workers sometimes share the profits, or you can say the salary of other health workers when they are not around. And then again, health workers who do not really have a form of political protection sometimes also pay the superiors in order to avoid sanctions. So we found out again under patronage system, we found out again that patronage system and clientelism exist in the primary health sector in such a way that health workers are given jobs as rewards, and this reward comes in forms of political support. When you support a politician, when you do the right thing for them, either they give a relative of yours a job or they give you a job, whichever one that comes first. Then again, we found that the system somehow is sustained in the process where powerful politicians also protect those people who support them. All of these things are what political protection that take place in the primary health sector mean. And then, of course, Prince Agu has already talked about the kinship network and, of course, family ties that operate in primary health centers. And just to give more information, when we talk about political protection, we are referring to people such as councillors, we are referring to local government chairmen, and of course, other prominent members of the community. But what we mean that these guys have the power to pull the strings. They could walk up to the local government and demand for a particular staff to be sanctioned. Moving further, we also found in our study issues about conflicting loyalties. Ordinarily, health facility committees have so much power, but majority of the time, there's a serious form of conflict. Now, when we say they have power, we mean that the health system put them there. Their job is to serve as the middleman between the facility and the local government. They are supposed to take care of the issues arising in the facilitate and of course report to the local government. But most of the time, because of too many powerful people in the community, they are in serious conflict. They find it difficult to report health workers who are related or who have some form of connection to politicians. Then again, OICs and HODs who hope to get favor rarely do not sanction health workers who are absent because of fear that this may hinder their chances of gaining in the future. So the conclusion of our study really is that we've come to see that in primary health centers, there are political interferences from powerful actors, and there are issues of interest and benefit, and of course the norm of godfatherism that afford privileges to certain health workers, such that two health workers may be in the same position but are treated differently. There's a political norm and power within the health system that creates a situation whereby two health workers are not the same. So to tackle political interferences, we are also recommending anti-corruption strategies that involve powerful stakeholders at the community level. We believe that this should be enough in order to galvanize action to tackle absenteeism and of course political interferences in the primary health sector. Thank you so much for this opportunity, Martin.
Thank you very much indeed, and also particularly for keeping to time. So we're going to go into the third country, Tanzania. And I'm just grateful to Helen and to Marta for posting questions on the board. We will come back to those immediately after the next presentation. So Peter Binyaruka from the Ifakara Health Institute in Tanzania. And now we're going to move on to another aspect of corruption. And in fact, this is something picked up in the questions where we're going to be looking at informal payments. And as we will be discussing later, in fact, this is a large scale project with a whole range of, looking at a whole range of types of manifestations of corruption, of which absenteeism and informal payments are only two. So I would refer you to some of the papers that have been published that look more broadly, but let's focus on this for now. Peter, over to you.
Thank you, Martin. So I'll take you through presenting the key findings from Tanzania, which will focus much on understanding the drivers of and preferred measures against informal payment for healthcare in Tanzania. So I'll present two aspects. So the first aspect is qualitative assessment, and then the other component is about quantitative assessment. So for the qualitative assessment, we conducted 2 rounds of data collection. So the first round involved 27 interviews, qualitative interviews with healthcare providers and healthcare managers. And also the main focus within this first round was to identify the nature, form, drivers of informal payment in Tanzania. And the second round, which is still ongoing, we are expecting to undertake 20 interviews with healthcare providers with the aim of identifying the mechanisms of engaging in informal payments and to understand the networks of corrupt practice. So in terms of what we have, in terms of the data from qualitative interviews, we identified who actually engage in informal payment. And here we found that all departments within a health facility do engage in informal payment, but more on outpatient department, surgery, emergency department, as well as labor and delivery wards. But in terms of medical cadre, we found that all cadre engage in informal payment, but more among nurses and doctors as compared to lower level staffs like paramedics. In terms of time, when these informal payments are happening, there's no specific time. But we found that most of the respondents were actually perceiving that this informal payment, they often occur at night and during weekends, and also during public holiday because there is limited oversight or supervision at a particular facility. And what are the key drivers in terms of informal payment? We found that low salary in terms of poor remunerations to these healthcare providers, shortage of staff, lack of medicine and supplies, all these influences informal payment, weak management, supervision, and this is more about the poor governance. But also we found some evidence in terms of cultural factors, for example, the perception among clients that the good services are provided when you engage or you pay healthcare providers. So you find that they have that tendency of paying these providers because of this cultural aspect. but also long queues as well as waiting times could also reinforce the issue of informal payments. The other emerging findings which we found is that informal payments are actually happening in networks, that it involves a network of different or chain of different providers, which ranges from medical attendants, nurses, doctors, and specialists, from the first point of contact to the end, which is the provider, the end beneficiary. And these are connected either through professional links or by having similar personalities or by working in the same department. In terms of informal payment, also we found that there is no one who protects them because people, they say that they know them, but there is lack of evidence to prove that these are the ones who are engaging and then to get punished or to be taken in a step further. There is no one who protects them because no one wants to be engaged in a corruption case. These people are known, but there is no evidence, and you might end up being hated by everyone because you are interfering in other people's affairs and you want others to be fired from work. So people just keep quiet. So this is, you find that this kind of problem or corrupt practice is just prevailing and continuing because of these kind of factors. Moving on to quantitative assessment, we had two approaches. So the first approach, we conducted a survey of around 432 public health providers from 42 hospitals and health centers in Tanzania. And the second approach, we conducted a disk choice experiment, DCE, with these providers. And our study sites were two regions, which is Dar es Salaam and Pwani, which are covering 11 districts. And in terms of the design of the disk choice experiment, we undertook 5 stages to generate the attribute and levels for this disk choice experiment. And also within those stages, we had opinion from experts as well as we piloted these attributes and levels. And finally, we generated 12 unlabeled choice sets or tasks with 2 hypothetical jobs. So job A and job B, where these providers could choose. And this is the final disk choice experiment 2, which we used, which included 6 job attributes ranging from modes of payment, where we had 2 levels. So the cash transaction, cash only, and the other level is no cash, which is more of cashless transaction. And this, to mention, these attributes were actually generated based on the qualitative findings, but also we tried to cut down to those which we found that they're making sense, that a provider could trade off to see the preference, how they vary across providers. And then the second job attribute is supervision at facility. So we tried to compare between rotating supervision at the facility 24 hours per day, or to have supervision just during the workdays. Also, the other attribute is opportunity for private practice, because we found that many providers are actually involving in dual practice, so they're having private activities for their for earning supplementary income. So we wanted to see how they prefer in terms of this attribute. The other attribute is awareness and monitoring. Here we included the issue of receipts, that providers should provide receipts on each transaction which is happening. And also the issue of notes board to improve awareness to clients. And also the issue of hotline numbers in terms of reporting informal payment for those who are engaging in informal payment. The other attribute, the 5th one, is measure to address informal payment. And here we had disciplinary measures to be taken either at the district level or at the facility level. But also on a positive incentive is to have a preferential training or promotion for providers in facility with no engagement of informal payment. And the last job attribute here now is about a monetary incentive, where we included incentive payment for staff for those facilities which they don't report informal payment in the past 6 months. And here we had 3 levels. So either no incentive, or to have 5% incremental salary top-up, or 10% incremental salary top-up. So these are the attributes and levels which we try to field in the disk choice experiment to see how they vary in terms of preference. So in terms of the analysis, there are 2 questions which are guiding us. So the first question is, what are the supply side determinants of informal payments? And the second question is, what are the preferred job attributes against informal payment, and how these preferences actually are varying across subgroups of provider. So the first part about the determinants, in terms of the analysis we analyzed using multi-level mixed effect logistic regression, hierarchical model, because we do know that individual providers are nested within a facility. So the preferred analysis here is the multi-level mixed effect logistic regression. And the dependent variable here is an indicator or dummy variable of whether a health provider asked for or given informal payment or bribery. And the explanatory variable, as I said, there are two levels, so individual level factors as well as facility level factors. In terms of this choice experiment to assess the preferred job attributes against informal payment, we analyzed using mixed multinomial lodged model, which allows for preference heterogeneity. And we also went further to undertake subgroup analysis to estimate now the preference heterogeneity. And also we estimated relative importance of attribute as well as willingness to pay for this analysis. In terms of the results from the survey now, first of all, about the prevalence of informal payment, we found that 27% of our providers whom we included in our sample actually confirmed to ever engaged in informal payment. And in terms of the significant determinants or drivers of informal payment, we found 5 significant factors or determinants actually influencing informal payment, which are ranging from individual level factors as well as facility or system level factors. In terms of the individual level factors, we found age to be a significant determinant in such a way that younger providers were more likely to engage in informal payments compared to the older providers. But also the medical cadre, those who are specialists or higher level in terms of medical cadre, were likely to engage in informal payment than those who are lower cadre in terms of cadre. But the other significant determinant was the position, the staff position at a particular facility. For example, being a head of a department or a unit, that influences informal payment. So they have that power to seek informal payment. In terms of the system or facility level factors, we found 2 significant determinants. First of all is supervision. So supervision throughout oversight at the facility was negatively related to informal payment, meaning that facility with throughout supervision were provided within those facilities were less likely to engage in informal payment. But the other significant determinant is provision of entitlement and benefits. That those providers who confirmed to receive entitlement or benefit on timely manner, they are less likely to engage in informal payment than those who don't. Why these factors? Why these 5 factors? In terms of explanation, the younger, they are often being termed as they receive lower salaries with much expectation than older. And for that case, they are somehow engaging in informal payment as a mechanism to compensate what they are supposed to get in terms of expectation as survival corruption. But also in terms of senior staff, they have power to solicit informal payment. And also specialists, they offer specialized services or emergent services which people could not have that opportunity to negotiate in terms of payment. And supervision actually limits chances of engaging in rent sinking, and also timely provision of entitlement as well as benefits relates to more earnings in such a way that we reduce the incentive to seek informal payment. The results from the disc choice experiment, so the 6 job attributes, we found actually most of these job attributes were significant in our analysis, in our estimation, except for few job attributes. For example, supervision throughout. This was not significant, as well as disciplinary measure being taken at the district level were not significant different as compared to being preference about disciplinary measures which are taken at the facility level. But also very interesting about the salary top-up or incentive. We found that they prefer the salary top-up from 10% as compared to 5%. If you can see here, that instead of having 5%, they would change their behavior somehow. You can perceive that way. From 10% salary increment is when they start seeing now the discrepancy in terms of preference. But as I said, we moved on to do subgroup analysis to understand now how these preferences are actually varying across providers of different characteristics. Overall, we found supervision throughout at the facility were less preferred on average. But if you look on subgroup analysis, you see that these were preferred by in charges of the facilities, and also were preferred by those with no supplementary job, and also health providers in hospitals. So you can see that on average, supervision was not preferred, but we see subgroups of providers who actually confirmed or cited this preference in terms of supervision throughout. For promotion or training opportunity, we found that it was more preferred by older staff, non-specialists in charges, as well as health workers in health centers. And also staffs with no supplementary job, low salary, those who are residing in rural, as well as native providers, those who are born within a district which they are serving. In terms of salary top-up, which I said 20% were highly preferred in terms of incentive than 5%. And this was more preferred among specialist providers and those who are engaged and those who confirmed to have ever engaged in informal payment. The issue of hotline for reporting informal payment was less preferred, especially for those who confirmed to ever engaged in informal payment, as well as native providers and those who are educated, especially those who have achieved the university level education. But private practice were preferred by native providers. So in terms of conclusion, regarding the drivers of informal payment, we see that there is a need to address system level factors, which includes adequate financing, better and timely remuneration, enhancing governance and supervision, based on the finding which we found from the survey about the determinants of informal payment. Also, based on the DC choice experiment results, we see that there is a need to improve both financial and non-financial job attributes, which we found they were both preferred. And also, we need to have enhanced supervision, especially in busy facilities, which, for example, hostels, which are quite busy with many departments, with many staffs. Also, there is a need to enhance career paths for this provider. It matters a lot, especially for among older non-specialists in charges, staff in lower level facilities, lower earners, and the rural providers. Financial incentives are actually expensive, we all know that, but matters a lot in terms of incentive. We see that 20% salary incremental were highly preferred. So all in all, our finding reinforces the need of targeted intervention which account for preference heterogeneity across providers as the potential way to reduce chances of engaging in informal payment in Tanzania. Thank you.
Peter, thank you so much for that. So what we're now going to do is take a little visual break, and I'm going to pass over to Dina, who's going to show a video clip from one of our colleagues from Nigeria. So Dina, can you introduce that? And then I think you're going to facilitate the questions, distribute the questions among our panelists, and also talk a little bit about the polling. Dina, over to you. And Dina, I can't hear anything from you in case your microphone is muted. Okay.
Before your salary will be paid. 18 days working duty.
Okay.
Before your salary will be paid.
18 days working duty before your salary will be paid. Okay.
Either the staff is in the morning duty or afternoon duty or night duty. The name must appear in attendance for 18 times. Without that 18 times, the staff will not be paid for that particular month. And ever since we said this strategy, it has been working.
So for how long has this strategy run now?
It's about 6 months now. 6
months?
Yes. No. Doctor comes to work at his own time, like when do. Mainly they do come if there is emergency.
Okay.
They will give a call, and the person will show.
So why the junior staff? Why are they targeting the junior staff?
The reason is best known to them, and they believe, understand the country we are into. Once you are a doctor, it seems to you you have read the apex. You know everything. And as a junior staff, as a nurse, a junior staff, you have no right to direct doctor or tell the doctor what he or she will do, since he's a doctor. See that it is working. I don't know of other departments, but this is human life. We know we are not God, but we will try our possible best. so that we resuscitate human life. It is now, since we are put, everybody must comply. The issue of writing a name for my friend, maybe you are living abroad, and I'm living here in Nigeria, and I have to put down your name, and learn how to sign your signature. At the end, you are there in abroad, and the money you paid into your account should stop. Sincerity. She started it. Don't write any person's name unless that staff is in maternity leave. And that if that person is in maternity leave, he or she must submit the paper indicating that the maternity has been issued to him or her from the local government sector. Issue came in during this pandemic, this yellow fever outbreak. The state government sent a vaccine to save people, to vaccinate people because of this yellow fever outbreak. People are dying. Some health workers dumped the drugs inside their rooms, and we were told the temperature will not exceed +2 to +8 degrees centigrade, freezing it before using it. They packed the drugs. Eventually, the state Ministry of Health went there in any ways to know if they are using the drug. Eventually, people are there, but the nurses are not there. They have to trace it. Who are the people? Who are the nurses that are supposed to be there, to be in that place at that point in time? They discovered these two people and they were sacked.
Did that story make people sit up?
Yes. Everybody working, every staff that his or her name appears for this vaccination period, always be there before 7. If not because I'm talking with people, would I be there before now?
Okay.
Dina, over to you. And your camera isn't on.
Thank you very much, Martin. Thank you very much, everybody. It is really important to actually capture some of the perspectives of our health workers, and we really wanted to show this video. It was a little bit unclear, but it's showing an intervention to, before you get paid, you have to be there 18 days, and there is a lot more community-based monitoring. So I would like to, we have some really good questions here. First of all, thank you everybody who are filling the polls. I can see you are very active with that. And anybody who joins, you could continue responding to the polls, they're active. So we have several questions. I would like to start with the first one, a question by Helen. So the first question is, Helen is asking us why, can you explain why you chose absenteeism among frontline providers as the object of your research rather than those who control staff postings, research allocation at the local and meso level? And I would like to go question by question. So this is very often a question that has been asked. It's almost like, why are we looking at, are the health workers in a way the recipients of the problems? Are they the right type of people to look at? And I would like to invite Aloy to answer this question.
Hello.
Did you hear me? Did you hear the question?
All right.
Yes, we can. Go ahead.
All right. Thank you. Before we started working on absenteeism, we actually followed a systematic process. One of those processes is that we conducted a systematic review. The systematic review is already published, and the aim was to see what are those health worker, what are those corruption cases that are very prominent in the health sector. And at the end of the day, we identified about 5 or thereabout, and absenteeism was quite frequently mentioned. And then again, we held the stakeholder workshop in Abuja, where we invited lots of stakeholders, people within the health systems and health sectors, very prominent people. So we used the nominal group working technique to understand what are those health sector issues that they feel is very challenging and of course can be feasibly addressed. After all the process, and once again, the paper is also published. After all the processes, we did ranking, and at the end of the ranking, it also fell on absenteeism. So we looked at it that absenteeism sounds very minor. People look at it as if it's a minor issue, but it's actually a very serious issue, because if you don't find the health worker at the primary health center, of course, no one will attend to you. And the biggest challenge with Nigeria is that some of the facilities located in rural areas have only about, say, 2 or 3 health workers, and they run on shift. And if you follow the video mentioned, I mean, the video earlier, it showed that you have to be at work to say about 18 times in a month. And the implication of that is that if, for instance, a health worker is posted to work by morning shift, if the health worker is absent, of course, no one will be attended to. I mean, no one would attend to the patient, regardless of whatever emergencies they have. And then sometimes some of these rural communities do not have any other option. If they don't attend, if they don't take these, if they don't make use of these primary health centers, getting to another facility location may be quite difficult, because of, we understand that primary health centers are not evenly distributed. So these are the reasons we focus on absenteeism. We see that absenteeism is neglected, it's not taken seriously, but it's actually a very serious issue within the health system. Thank you.
Thank you very much. Great answer. I just wanted to say that the team is presenting here only the findings from health workers, but we are finding that the issues around absenteeism concern cadres that are in the district management, in the local government. So we are looking at a much broader range of factors. So the next question from Ariel, it's a great question, actually, really trying to suggest that there are a lot of opportunities for local authorities, and he's asking, what are the role of health authorities in promoting social accountability and informed citizen participation that could overcome power inequalities at country level? So this is a perfect question for Professor Masood. I would like to invite you to answer this. You recently did a review exactly of the opportunity and the application of social accountability approaches in South Asia, and you really can give almost a quick regional remarks. Prof. Masood, over to you.
Yeah, thank you, Dina. Yeah, I mean, we just finished a review of this this phenomena. Yeah, I mean, there has been, I mean, lots of attempts being made to, to curb this this problem of absenteeism and this corruption, all these things. But ultimately, these were all traditional measures of carrot and stick, and ultimately they didn't work. Even our Prime Minister herself directly and threatened even the physicians with stacking and all these things, but even that it didn't work, because it's so, the medical establishment is there so powerful that it has also the history of toppling the government as well. So those top-down approach actually doesn't work. So there are many, there are quite a few, I would say that attempts are made to make those people in power or those people who are involved in providing the healthcare services to bring them into account. And not only health sector, but as well as in other sectors also. And the experience shows that sometimes it's quite effective, but all the experiments that have been done was on a small scale. So that's the problem of, there is the problem of scaling up, and then also there's convincing these, these bureaucrats at the health system about the utility of this particular approach to, to make these people accountable to people's, people's rights and the demand for health and all these things. So yeah, it's quite challenging, I must say.
challenging, and also we don't have evidence. That's what one of the conclusions of our paper is, that actually we don't have enough evaluation. It seems to, Ariel, it seems to work better in Latin America. It doesn't work the same in every region. I think we need to do more to understand the link to political culture. So one more question from Marta, and I would like to ask Peter from Tanzania to comment on that, because that came up in his work. The links between absenteeism and informal payments. Do people pay for posting? Are there any sort of links? And I think you can say something around that.
Thank you, Dina. Yeah, in terms of absenteeism and informal payment, generally you can see a link between that. But in terms of, and also to mention for us in Tanzania, in terms of our research, we actually had those two aspects together as some key issues, key concern actually to be looked at in terms of informal payment as well as absenteeism. And some of the drivers are actually similar in such a way that some of the drivers which are influencing absenteeism are also influencing informal payment. But I think the key question you're asking in terms of the linkage now, if people are paying for job posting, and for that case, we didn't get that link because we didn't go in detail to try and see how the posting and the absenteeism, how they link with informal payment. But there is a clear link, could be that possibility. But for us also to mention some contextual aspect in Tanzania of job posting being more centralized could also explain that possibly there could be, there might be not that possibility to have people paying for them to be posted somewhere, unless you have that high level or political network in terms of people whom you know at the top level. But for lower people at the lower cadre, it's quite difficult for those people who don't have that connection. You can't do that. But for those with higher connection, they can do that. There is that clear link in terms of job posting and paying informal payment. Thank you.
Thank you very much. We have a few more questions coming in, but I suggest that we leave this for the next break, so we make sure we're on track. But we have these questions for the next segment. Thank you very much.
And Dina, do you want to say anything about the polling at this stage, or do you want to keep that for later?
No, we are going to keep people already responding. So they're responding already. It became automatic. So I didn't realize it starts automatically. Already a lot of people have responded. Those who haven't, please choose an option and enter it.
Thank you very much indeed. So you have now heard an overview of the program from Mushtaq, and you've heard some of the evidence, some of the research that's been undertaken in the 3 countries. And what we're now going to do is to move on to a sort of synthesis in which we're going to go back to Dina and to Eleanor Hutchinson, who are going to look at some of the comparative themes that are emerging from the application of the ACE theory. So I'm not sure which of you wants to lead on this. Eleanor, do you want to start? I see you.
It's going to be me, yes.
Good,
Hi,
Eleanor.
everyone. Let me just bring up my screen. Great. Thank you very much, Martin, and everyone for joining. It's a great pleasure to be here. So I've got a very short amount of time to whip through some slides to think about comparisons across the different countries that we've been working in. So all of these findings were found as we were working through the qualitative findings across these 3 different countries. So I think just a quick recap for health. So Mushtaq set out the whole of the Soas ACE approach. And I think when we think about health systems, we have to think about, where we've got to in terms of anti-corruption research. So we know, as has happened in other sectors, that transparency and accountability approaches haven't yielded the results that we'd hoped for. And the reasons that we think that's the case is because they focus excessively on individuals and they ignore the context in which people live their lives and the contexts in which people provide care. So these are, so we'll go through what the particular bits of the context are in a moment. The other thing that transparency and accountability approaches have done, which I think is particularly salient in health systems as we sort of grapple with the call to decolonize global health, is the fact that accountability and transparency approaches can often, especially when they're embedded in good governance, can often create this very unhelpful benchmarking process where you compare low and middle income countries constantly against high income countries and look at the sort of the lack of progress. And you don't actually look in terms of really understanding the context and the historical context in which we're trying to tackle corruption. So what's happened is across other sectors, but not so much in health until now, there's been a real search for new approaches to anti-corruption. And these approaches take context, social relations, in particular networks and social norms, but crucially, and this is really important for our work that we've done, takes politics into account. And if you want to know more about this, we have a paper that teases out all of these older approaches and the new approaches and their significance for health systems. That paper will come out in BMJ Global Health imminently. Okay, so Mushtaq discussed briefly the Soas ACE approach to anti-corruption. So embedded within that, we have this idea that there are really 4 key strategies that we can use to create targeted, high impact approaches to anti-corruption in health. And I think it's also worth underscoring here that we're only interested in anti-corruption that makes improvements in health systems. Anti-corruption is a means to an end. It's not an end in itself. So if you get anti-corruption projects that are very good on stamping out corruption, but actually impede the delivery of care, then we think that those really are, they're obviously strategies that we don't want to embed around the world. So the 4 strategies that we think can impact on anti-corruption to improve health systems, the 4 strategies presented by ACE are changing individual and group incentives, creating policy that recognizes and acts on the difference between actors usually seen as homogenous, and then working on that to create new forms of collective or connective action amongst groups who are powerful enough to affect anti-corruption change. So they may become powerful because you get a lot of people together, or they may have particularly powerful individuals embedded in those groups. And for us, we've added an additional one, which is really about targeted anti-corruption investments that will improve the health system. So that's the way that we've interpreted the Soas ACE approach into health. And what I want to do now is pick up on the 2 middle points, creating policy that recognizes and acts on differences between actors and creating forms of collective action. And what I want to do then is draw out one of the common findings across countries, which is really about the importance of understanding how actors are differently situated in different social networks. And what's critical here, and we say over and over again in our research, is that you cannot use blueprints to tackle corruption in health systems. And part of the reason that you can't do that is, okay, health systems are different, but the social networks that control access, that do informal payments, or control the way that absenteeism is embedded in particular countries, are always going to be different. So we find very different types of networks. In Bangladesh, we have socio-economic and political networks that can provide access to better postings. If you're very well politically connected, the chances are you won't have to make an informal payment in order to get a better posting. But you can use socio-economic networks to facilitate better postings if you're less well politically connected. But we also found health workers who weren't politically connected at all and didn't have the economic wherewithal in order to buy postings and ended up, as they felt, trapped in rural areas. I think it's worth mentioning also that networks fail sometimes. They don't always work for everyone. And maybe that's something we can discuss later, is whether they fail more often for women, whether there are gendered implications here, that we can build on to create effective strategies. Of course, local networks, on the other side, can improve the experience of rural postings. And we saw that strongly in the Bangladesh findings. In Nigeria, we've seen very strong political networks that provide godfathers and godmothers who protect corrupt actors, so that you can be absent from a health facility. Essentially, you can act with impunity. There's no one there who is going to be able to sanction you. And probably with very good reason, that there are other health workers who are too afraid to report people as absent because they know they have very powerful actors working within the health system who could make life very difficult for them. But obviously we also have socio-medical networks between doctors and between administrators who protect one another. And really, I think one of the points here is to tease out who's involved in these networks and who's excluded from these networks, and whether we can actually build on the people who are excluded in order to challenge the networks that are at play. In Tanzania, we found really two different types of networks. So socio-medical networks embedded within frontline providers who work together to extract informal payments, to distribute services amongst patients and extract informal payments for them. But we also found networks of doctors who refer patients to one another and then take and distribute informal payments as they do those things. What we've tried to do then is to think about how we can start to use this approach more effectively. And we've come up with this illustration of the way, and I'm sorry, I'm just trying to move around my Zoom screen so I can see it effectively. This sort of illustration of how we understand health workers as positioned in the health system in order to come up with feasible, targeted anti-corruption approaches. So as my colleagues from other countries have said, all health workers, in some ways are the same because they are all subject to the same formal policy context. They are all subject to the same health system context. So there may be anti-corruption policies governing behavior, there'll be key policies governing different cadres of health workers. But then the health system may be well-funded or underfunded, the condition of the infrastructure may be very poor in some places, there may be heavy workloads. So in this way, the health workers if you think about junior doctors situated in rural areas, may appear to be a homogeneous group. But when you start to unpick the social networks, which are highlighted in green, you'll have health workers who have more powerful or less powerful networks that govern their access to these informal ways of distributing resources, be they financial or be they posting. And that's where we can start to unpick which health workers we think would want to be more or less involved in anti-corruption strategies. We suspect that those who are connected to very powerful political networks are much less likely, but people for whom networks fail or people who can't use these informal strategies so effectively may well be the people that we want to connect together, who can come together to push forward anti-corruption change. And the final slide is just a recognition of all of the people who've been involved in this research. Thank you very much, Martin.
Thank you so much for that, Ellen. So hopefully that brought things together in a way, making the linkages, the connections between the different, the work being done in the different countries. Now, you will have already seen in the presentations that we draw heavily on the methodology of discrete choice experiments. And in this, we have been very fortunate to be guided by Blake Angle from the George Institute, and a particular thank you, Blake, because you're actually calling us from Australia, I think at the minute, and you're currently about 3 o'clock in the morning. So I think definitely the award for perseverance goes to you in this presentation, in this session, for staying up so late, and thank you very much indeed. And let me hand over directly to you to tell us more about what we've been doing.
Thanks, Martin. I'm getting the jet lag experience, if not the travel. Thanks to everyone for joining us today. So as Martin mentioned, I'm just going to give a quick overview of how we've been using discrete choice experiments in the 3 study countries that you've been hearing about today, and also looking at how the results might be used to inform policy development. So we've heard from the speakers today about some of the complexities that both drive corruption in health systems and also complicate efforts to overcome it. We know there's many reasons that drive healthcare workers to engage in corruption, but we don't really have a good idea of how these differences impact on strategies attempting to overcome corruption. So again, as we heard earlier, structures within the health system can make some groups more susceptible to change or policy intervention than others. So basically, to investigate these issues, we've used discrete choice experiments to look at the preferences of service providers over potential interventions to overcome corruption. As Peter showed you earlier, basically discrete choice experiments are a type of survey where respondents are asked to choose between two or more hypothetical alternatives that differ on the basis of a number of attributes that vary between each possible choice. What we do then is, by analysing the responses of participants, we estimate the relative importance and the value placed on each attribute by the participants. So I'm going to focus on the Bangladesh data for this presentation. Very quickly, we've basically been using the technique as a means to build on the qualitative and literature review work that we've already heard about. So from this work, we've essentially found 4 drivers of absenteeism that we thought might be amenable to intervention in order to overcome absenteeism in Bangladesh. From these, we distilled this into some quite specific key intervention in a similar fashion to what you saw earlier from Peter's presentation in Tanzania. Basically, we use this series, these policy interventions, to build a series of scenarios to present to respondents that change according to these key areas. So looking something like that. By analysing the choices of respondents, we were looking to investigate the feasibility and acceptability of these interventions to the doctors themselves, the trade-offs that doctors were willing to make between carrot and stick approaches that might encourage greater compliance among the doctors that we're trying to affect, and whether we could identify subgroups, as Eleanor was just speaking about, subgroups of doctors that were particularly susceptible to intervention, at least as a starting point. So these are the results for the full sample. So this covers the same 308 doctors that Rehan was speaking about earlier. So this graph shows the estimated coefficients for each attribute. Very quickly, basically a value of 0 indicates that there's no impact on the choices of respondents. Those attributes on the right are positive predictors of choice, so doctors were more likely to choose the job when that was present. And to the left, essentially the potential of disciplinary action for poor attendance was disliked by all respondents. So the key things to take away here, I think all variables significantly influence the choices of participants. What this means in practice is that the doctors were willing to accept trade-offs between the different attributes. So they were willing to put up with the possibility of being punished for poor attendance if it was balanced out by more positive attributes, such as the potential for further training for good attendance, for example. But overall, the biggest impact was whether it was opting out. So where the respondents said that they would not take the job offered and instead stay at their current job. So this sort of highlights the challenges with getting people back into rural areas. There was significant variation in our sample though, which we quickly can look at here. This is something called latent class analysis. Basically, this groups respondents with similar preferences into different groups. And there's 3 distinct groups coming out in our data. So these are the estimated coefficients for each of the attributes. So the group 1, which represented 21% of the sample, essentially you can see by this 3.86 coefficient, which is very big, essentially they're unlikely to accept the job. They are willing to trade between some attributes, but essentially what this is suggesting is that any policy package that is able to entice these people to accept one of these rural placements is likely to be too expensive to be realistic. On the other hand, on the right, the group 3 with 32%, essentially they almost always accepted a job that was presented to them. So you can see that they've got the coefficient is for the top for the opt-out constant is a negative, which basically means they were always willing to accept the job. Meanwhile, the group in the middle is seems to be what this sort of sweet spot for intervention. It accounted for almost half of the sample. And while they preferred often to opt out, they were willing to trade and would definitely accept jobs if they were constructed in the right fashion. So just to sum up, understanding the incentives facing healthcare providers and how these are driving behaviour is crucial to overcoming corruption. And we're using DCEs as a tool to do this. Most providers will accept the presence of negative attributes and higher levels of monitoring if balanced out by more positive features, and hopefully better targeting of interventions to overcome corruption at those most susceptible to change may hopefully be able to improve the impact of those interventions. Thank you.
Thank you very much indeed. And now I'd hand back to Dina, who is going to give us another video, this time I think from Bangladesh.
Recently, we conducted a study, a mixed method study, to understand the perception of the people and the trust of the people on the health system of Bangladesh during the COVID-19 pandemic. And we realized that the perception regarding the corruption, is actually one of the major driving force of towards the people's trust or mistrust, for that matter. Our respondents basically pointed out to several incidents that made to the media. For example, they talked about the personal protective equipment that were found to be counterfeit, yet received by the health department, allegedly due to the connection between unholy syndicate between the suppliers and the people who received from the health services. Several decisions to protect the interest of the businessmen were seen as an offshoot of the political consociation. We found a mushrooming of unauthorized and even fake testing centers. And later we realized it was found out that the people who received the approval from the government bodies, those people were related to the political party, the ruling party. So the people, our respondents basically suggested that there should be transparency, there should be punitive actions against the people who are doing this type of activities, dissolve any unholy syndicate, ensure accountability, and regulate the private sector for cost and quality of the services. In order to do all these things, people should be empowered, because as long as people are not empowered, they cannot raise their voice, they cannot really hold the decision makers accountable for their activities. So any intervention that leads to citizen empowerment will eventually pave the way for curbing corruption. Thank you.
Lovely. Thank you very much indeed. So we will now move straight to our panel discussion. And if I could invite our panelists to all open up to switch on their cameras, switch on their microphones. And I'm delighted to welcome Professor Abina Onwujekwe, who is from the ACE team in Nigeria, the University of Nigeria, and is certainly one of the leading thinkers, the leading thinker, I think, in Africa on corruption in the health sector. Rachel Cooper from Transparency International. Dina, you've already met, and Mushtaq, you also have already met. So can I see all of you and maybe put you into a gallery view so I actually get you there? Yes. Good. Thank you very much indeed. Great. So we've heard about all the challenges. We've heard about all the problems. What are we going to do about it? Mushtaq, you come from outside the health sector. And this is, in a way, although you've got to know us very well over the last few years, But I think at the beginning we were a bit different. You weren't quite sure what to make of us. Having listened to all of this, what are the ways forward? What have you taken from this program that you see as sort of messages about making things work, moving forward in a practical way?
Thanks, Martin. No, I think that there are the details of the health systems are different, and the health sector evokes a lot of emotional responses from people who work within it. But I think the problems are fundamentally quite similar. And I think a lot of common learning has come from working together with LSHTM and other colleagues in the health sector. Let me just reiterate something that came out very strongly in all of the discussions, which is very important. When you look at corruption and rule violation in developing countries, it is actually overdetermined, which means that there are lots of reasons why this is happening. The point is that not all those reasons are reversible. And this is where I think a lot of confusion and problem starts. We heard our last speaker say, talking about the COVID-19 related corruption in Bangladesh, if we could have more accountability, if we could punish these people, if we could break up these syndicates, the corruption would go away. Absolutely. The point is that it's very unlikely that we can, because as the speaker himself said, these are people directly connected with the political party. They're very close. The citizens are relatively weak and bad and not so well organized. The ACE approach, and this is what we are seeing in the application to the health sector, which is so useful, is that it not only asks us to think about the causes of corruption, but asks us to identify those causes which can be reversed. In other words, where is the feasible anti-corruption possible? And even if that doesn't get rid of all of the corruption, it might make a significant impact on the outcome and create the appetite for more changes. And I think this heterogeneity of actors is a really important area. And it's one that we have to really focus on. If almost all doctors are violating the rules, and if almost no doctor is present all the time in rural health centers, you can't punish them all. And I think what it shows is that the reasons why they're doing this are quite different. Some of them are doing it for quite reasonable reasons, like they don't have security out there. And some of them are doing it for very unreasonable reasons. They want to use their political connections to not go there and do private practice. And I think we really need to distinguish between reasonable reasons and unreasonable reasons. And if we can do that, we can then target our intervention in a way that is supported by the vast majority of doctors. So I think here's the real issue. The strategy that we come up with, whether in health or whether in any other sector for anti-corruption, must be supported by a lot of people within the sector. You can't go and say, we're going to enforce this and find that 90% of people are against you. And I think this heterogeneity of preferences is the health sector application in absenteeism of a general Soas ACE strategy, which is designing for difference. We want to split the rule violators into different groups. The really hopeless groups that we want to target, the bad eggs, and lots of people in developing countries who violate all sorts of rules on a daily basis because the system doesn't work for them. And many of those things can be fixed. Many of those things can be improved. And in that way, we can make those incremental improvements. So it was a great experience working with the health sector. And I think there are lots of other questions coming up as we are doing our research, which can move this approach forward. I know you want to break in, Martin.
Yeah, I do. I just want to bring on and some of the other panelists. So Rachel, having heard all of that, one of the things that Transparency International has said again and again and again is that the health sector is consistently one of the areas where you find the most corruption in a country. Now, listening to what Mushtaq has said and listening to the panelists, are you any more optimistic that we might be able to get to a situation where your annual country reports don't put the health sector as the most corrupt? I'm not saying we should try to make other sectors more corrupt to compensate. It's not a competition. But are there ways in which you think we can move forward with this? Does it give you an optimism as we look forward?
Thank you very much. I think that there is cause for optimism, partly in that we're beginning to get and beginning to do. And as several speakers have said, we simply don't currently have and are only just beginning to do that research, and the ACE research and the granularity that it gives, I think, it is a bit hopeful. I think that these approaches are never going to really progress us alone. And I also think that there is a role for, for a bit of the kind of the brave discussions, the confrontational aspect that, if you like, some of the indexes that Transparency International works with, and I think that those enable us to highlight the importance of the macro issues and the macro approaches as much as the micro. So when I'm talking about those, I'm talking about not necessarily thinking that it's the solutions that we can implement at the macro approach, because everything that we've seen and as the research indicates, big kind of blanket macro approaches don't necessarily deliver the results. But corruption sensitivity and really thinking ahead and getting governments, multilateral bodies, and all programmers, all those that are developing programs, policies, guidelines, and are then implementing projects, to be thinking ahead and implementing as part of that. Where are my vulnerabilities? Where are the risk factors? How am I going to measure whether those are manifesting? And I'm not talking about, about kind of audits and, the tick box exercise. I'm talking about much more holistic, sensitivity approaches that can cast that the other side from the research that the ACE programs is delivering. So
okay.
do I sense a bit of optimism? Slow.
Well, let's see if we can find a bit more cause to be hopeful. Obi, you've been engaged in a really interesting exercise, a stakeholder analysis. Now you've disappeared from my screen. Are you still there? Obi? I'm hoping you're going to come back in a minute, because I think you may have lost the connection from Abuja. In that case, maybe I'll come to you, Dina, if I may, and really ask a question that I would have asked Obi. I will ask him if he comes back, which is that in Nigeria, they've been engaged in this stakeholder analysis. They've been talking to people. Now, I'm sitting in London. We've just had a National Audit Office report into procurement in the United Kingdom. And when I'm talking with Obi, I often joke with him that we desperately need him to come to London to do some consultancy on how we're going to sort out the corruption here, because we clearly have a huge problem that we're not talking about, or only beginning. People like Joe Mom and others in the Good Law Project are beginning to talk about. But I think we've been struck by the way in which they have found a more receptive audience there. And I hear that, I see that Obi is coming back.
Back, yeah.
So if you are back in, Obi, can you hear me now, Obi? You're muted, and hopefully, Obi, are you? Well, but while we're waiting for Obi, maybe you could reflect on that a little bit, Dina. And
yes,
Obi, oh, you're here.
I'll hand over to Obi, and I'll build on it.
Okay, so what we're asking about is you've been talking to people in Abuja, you've been engaging with senior political leaders and others who've actually been quite receptive to doing something about corruption. And was that a surprise to you? Does that give you hope? Does that make you feel, I mean, is it more than they're saying the right things? Are they actually, are they actually going to take these things forward?
Yeah, no, sorry, I didn't get the question. Take what forwards, please.
We're really asking how optimistic you are based on your conversations, the stakeholder analysis that you did, for example, looking at people, the attitude of leaders in the health sector and beyond who really do seem to be engaging with this issue. How positive are you?
Well, yes. Well, I'm positive. It depends on the different levels. You know, different stakeholders at different levels. At the frontline health worker level, I mean, I'm very positive that things could be done about absenteeism, because the stakeholders that hold the control at that level, are ready to work on that, on absenteeism. So at the lower levels, I'm very positive. It becomes more complicated when we move up, higher on the, higher the level, at the level of ministerial level and that level. So that's where, because health is not, I guess part of the reason that the health is not really a big priority of politicians. So they tend not to look into there, into what happens there. But if you can catch their attention, then something can happen. But I think the alternative we also have, as promoted by ACE, is, having something at the horizontal level. If you can have a mass mobilization of interest, and the sensitizing about what is happening, then we can do something. But if you don't have this horizontal approach, where a lot of the stakeholders that really matter, a lot of civil society organizations and community-based organizations, if we can mobilize them with the evidence we have, then things can happen. But I just also want to point out the issue about the role of development partners, within countries. Do they cause problems? Maybe we can hope to hear Transparency International look into that. When many development partners move into countries, they just want to tick their boxes that they've done something. They just bring money, they don't care how the money is used. So sometimes they actually promote corruption within the country. So I think, so corruption happens within countries, but it's also influenced by the people that come from outside the country, by all of them wanting to implement programs or to give loans, and they never bother to track what happens to these loans. So I think we really need a holistic approach. But I'm really optimistic at the lower level that things can happen on absenteeism. That at high level, it needs a lot of big conversations. And I think one conversation we need to have is development partners pumping billions into countries and not caring where the money goes to, because they just want to tick their boxes that they've done something in those countries. So I think that's where it is. But I think until we get the attention of the highest level political actors to think a lot about the health sector, then it's be difficult to get things to happen at the highest level. Because I mean, the budget, how much goes into health? They look at it; it's small. They bother more with power, with road and infrastructure. So, thank you.
Yeah, thanks very much, Yobi. So, Dina, can I ask? Do you want to respond immediately to that, and then I've got a question for you. Go ahead.
I just want to actually make a short, very quick comment, responding to some of the questions in the box which people have asked us, and I think we have a really good example in Nigeria. As you know, in Nigeria, we have health facility committees at every facility. And some of the interviews OBN team did in the last few months were illuminative, because some of these, for example, chairman of a facility committee is telling us that they would like to clamp on some types of absenteeism, but they can't, because they get a call from the local government, or they know who is employed by whom. So a lot of they have what's called godfathers. They have various other figures where OBN team identified almost more than 15 figures. So what I would like to say in response to Ariel and Helen and a few other people, there are local community organizations that have potential. So the question is, can they be linked to actors who see themselves as benefiting from anti-corruption? And we saw in our initial meeting, which we published the results of the first exercise, that there are actors who see political credit in addressing corruption. So there are possible alliances, but we need much more in-depth understanding of the actors who are involved in all this, not just in the health system.
Rachel, can you give us any examples of where that has worked elsewhere?
Yeah, I think this question of kind of building the field of around anti-corruption approaches is absolutely critical. And we've seen it very clearly in some of the work we've done about procurement transparency, mainly in sub-Saharan, so in Uganda, in Zambia. And that field, and you're getting some of those community actors that Dina was just referring to engaged. It is about making and establishing the relevance. With those acts, not about talking about anti-corruption, it's about demonstrating very visibly that if they have, in our case, if they have access to the about the facilities that are local to them and what those facilities are meant to be doing and what infrastructure they're meant to have and what provisions they're meant to have, that then you are really beginning to equip those local organizations with, with the kind of building blocks for accountability. And those are, I mean, we've obviously been focusing on the health sector this afternoon. Things are also transferable and translatable from other core sectors. So for instance, from education. And I really think that this is a critical point that we can sometimes be very sensitive about talking about corruption or anti-corruption. And actually a lot of the time when we're really at the micro level, it's much more about giving the visibility and the accessibility to enable accountability.
Well, that's very much aligned with your approach, Mushtaq, isn't it? It's this idea of enabling people and getting those people of goodwill to come together for a common cause. And but you do have the bad eggs, as you call them. And I was just wondering about other groups, and I'm really looking for Rachel and you to come in this, because in this country, what we have seen is what the British government call disparagingly activist lawyers with judicial review. We've seen the tremendously powerful role of investigative journalists, and in particular in other countries in Europe, in Malta and others. So I'm just wondering about that stick bit as well, because the carrot is there of saying, well, actually we can reorganize the system to make it so that you don't have to engage in corrupt practices, because sometimes you're doing it as an adaptation to a dysfunctional system. But what about the stick? What is the role for that in your model?
So can I come in, Mike?
Please, yes.
Yes. So I think that the one thing that happens in developing countries and happens a lot less in advanced countries, I think they're common in the sense that politicians will misuse power and power will be misused. I think that a lot is in common. The one thing that is very different in developing countries is that the voices of those who would like to comply with the rules but cannot because the system doesn't allow them to are swamped. And I think this is what we are uncovering, is that there are lots of opportunities here. I'll give you a quick example from another field. Rachel talked about education. We have a big program on skills training in ACE. Billions of dollars are spent by developing countries trying to develop skills. The treatment effect of skills training programs the World Bank has found is between 0 and 10%. In other words, zero effect. Billions of pounds and dollars are spent and having no effect. Why? The problem is that the way they incentivize it, they say the skills training providers will get paid according to how much employment they create. Now, there's enormous fraud in misrepresenting the amount of employment so that they can get paid. We spent a lot of time digging into the dirty details and found a really interesting fact. In Bangladesh, there are lots of training providers who engage in no fraud, and they happen to be close to factories which have high capability and are swallowing up their trainees, so they don't need to do fraud. And a lot of training providers happen to be near clusters of factories which have low capabilities, where if you send them skilled workers, they don't employ them because they think that they lack skills, but actually the factory is badly organized. And those guys, if the factory is badly organized, you can send a skilled worker there. They don't raise productivity, they don't get jobs. They prefer to hire people from the street. Now, this has an enormous policy significance, because we also know from other research in Bangladesh that if you combine advice to factories to improve their organization and then combine it with skills, productivity goes up 30%, and there's no fraud by the training provider. There's a simple solution here, which would take 70 to 80 or 90% of training providers out of fraud and leave the bad eggs that we can then deal with. Whereas now 70 to 80% are engaging in fraud, and no amount of transparency, accountability, punishment, procurement reform, including monitoring done by development partners like FCDO and DFID, have had any effect. Now, this is the kind of thing which is solvable. We should go to the more difficult problems of how to contain power and politics and so on a little later. Let's fix the problems which are massive. I mean, this wasting billions of dollars of money, and it's a fixable problem. And it's the same with absenteeism. These are fixable problems.
So Obi, let me come back to you now. These are fixable problems. In the list of priorities in Nigeria, which do you see as the fixable problems? Because as I put into the chat earlier, your systematic review of corruption in the health sector in Anglophone West Africa that you and colleagues led. So there are a range of things that need to be tackled. What's top of your list?
Well, I think absenteeism is top of my list because it deals directly with patients, and then it can lead directly to loss of lives. But followed by, I think, procurement-related corruption is because of the huge amounts involved that can be more efficiently deployed. And then, we can now talk about other ones, including informal payments. But I think if at the lowest level we can sort out absenteeism, and at the highest level, well, we cannot eradicate procurement-related corruption. But at least we can decrease it so that it's manageable, and then commodities can now get down to the lowest level. Because there's some reasons why health workers give why they are absent from work is that they don't have anything to work with. So the problem has already started at procurement level. So if you can sort out these two levels, procurement and absenteeism, I mean, these are the topmost, then we can get the system working, and then we'll see how we can deal with the other issues.
So this is a very important point. There is no point in somebody as a health worker going to a facility if they don't have the tools to work with. I quote in one of my lectures on Dina's course from the Irish travel writer Dervla Murphy, who visited a hospital, was actually in Pakistan. And it had a list of all the times it was not closed and it had no equipment. And she said memorably, this was not a hospital, this was a statistic. So there was no point in being there, in fact, because there was nothing to do. We're getting near the end, and I just wanted to ask Rachel a question from your broader view.
Martin, before you, I just want to announce everybody, we just reposted the question on what can be done about corruption in case you change your mind. You have another 3 options. Please go on the last question on the chat. Thank you.
Okay, and I'm going to hand over to Dina to wrap up in just a minute. So very briefly, Rachel, because you only have about a minute to answer this, it's really picking up on Mushtaq's thing. Are quantitative targets, tick box exercises and so on, intrinsically corrupting unless they're designed in a way that they actually won't be corrupting? So when we're holding governments, we have targets and so on. What do you think?
I think it's, as everything, it depends. It's totally contextualized. Examples that we've already heard when we're talking, for instance, about donor funding, multilateral programs. In those cases, I think that quite a lot of the time, the tick box exercises, which are driven as much by the push factor of delivering a program and getting the money out the door. I think in those yes, and I think that we would be better doing corruption sensitive analysis.
Good. Thank you very much indeed. Now I'm going to pass over to Dina for the last word. Dina has been responsible for pulling all of this together. Thank you very much indeed. And thank you to all of our speakers, but you have the last word.
Thank you very much. We'll have further engagement with you at some point, so stay tuned. But I just wanted to summarize. We are looking at corruption as a range of events, range of manifestations, and what we're trying to explore and what the gaps in the international research agenda are. What are the institutional and political drivers of corruption? What can we do that's beyond transparency and accountability, which clearly doesn't work always very well by itself? but really trying to understand the incentives for different actors to be much more targeted towards actors who actually are keen to follow the rules, they're keen to advance their career and do it in the right way, and those who have different incentives, to distinguish between survival corruption or opportunistic corruption. I think we're finishing, but please stay with us on this space. We'll be connecting to many of you.
And thank to all of our speakers. Thank you to those of you who joined us in the session. Thank you for your questions and your comments. And watch this space, because there is an awful lot more coming out of this program. Thank you very much indeed, and goodbye.
Thank you.
Thank you, everybody.
Bye.
Email us with any further questions and contacts. You know where to find us. We'll definitely do another symposium just on corruption. Thank you very much.